Hi, Dr. Shiller here. I am here today to try to answer a question that a number of people have asked my office staff. They've called up and they've said, he does integrative pain medicine. That sounds really interesting, but I'm not in the same location. Can he really help me by telemedicine? Doesn't he have to put his hands on? And so the answer to that question is yes and no. It sort of depends on the circumstance. And I'm going to try to flesh that out for you a bit. And one of the things I want to clarify is that pain, when it's continuing, whether it's months or years, is typically much more than just that structural thing that happened to your back or your knee or whatever it is. I mean, it's a reasonable question to think, well, okay, I hurt my back, so someone needs to examine my back. But my guess is that if you're calling, it's because you've seen specialists who've done that and you're still having trouble. And frequently that means it's a broader problem than just like what can be addressed by the procedure or the intervention or the injection or the drug. I want to talk about talking more broadly about pain because it might flesh things out and help you understand and see if it makes sense for you to set up an appointment. First thing I want to share is let's look at these slides up here a little bit. This is the pain processing system. It's a slide from Scientific American. The main thing I'm trying to illustrate here is that if you have something that, like a burn or an infection or something in your hand, it generates pain. That signal goes through the spinal cord, the brain stem, the midbrain, before it gets to the part of your brain that says, ow, I've got burning in my hand. And what happens in the spinal cord and brainstem and midbrain is that pain is modulated. There is a pain processing system, which is kind of like an amplifier with volumes that can turn it up, turn it down, shift various parameters of how it feels. So it's not just like flipping a light switch, it hurts or doesn't hurt. Your experience of pain is not just what happened to your tissue, it's how your brain, your spinal cord is responding to and understanding that, so to speak, and interpreting it. So let's understand that more. What is this pain processing system? What influences? What turns up the volume or turns down the volume on those amplifiers? The first thing to think about is your metabolic system of your entire body, right? So these are variables that can turn up the volume on pain. Stuff like inflammation, nutrient deficiencies, biochemical stress, hormonal impairments or deficiencies or imbalances. That can all change the way your body processes pain, and these other variables can affect those things. These are all influencing each other, right? Gut dysfunction, toxicity can drive inflammation and oxidative stress, can mess up cellular energy production. All of that can mess up the way your brain processes pain and make you sicker. That can cause nutrient deficiency, hormonal deficiency, and all of these things are driven together as one unit by something called autonomic imbalance. And that's basically overactive stress response, whether it's from the injury, from trauma, from genetics, from metabolic factors that can increase autonomic imbalance. So let's take all of these complex things and lump them together and just call them metabolic system. So metabolic system can affect pain processing. Next thing is how perceived pain and your emotions are intimately connected. And most people know this intuitively, and for sure pain science is catching up with common sense and showing us over decades that a person's pain processing is profoundly influenced by their mental emotional state, their beliefs about pain. You know, one great example is catastrophizing, which is a measurable psychological construct. And it's not just, oh, the pain's in his brain, he's amplifying it. It's no, the pain processing is turned up. The brain changes in response to chronic emotional distress and negative belief systems. And here we got that autonomic imbalance involved in that because it also drives that whole situation. So this whole perceived pain, connecting with your emotions, your beliefs, your sense of meaning, and your autonomic system, let's call that your mind-body system. And so let's put it all together, right? We got metabolic imbalances, mind-body system, and then whatever is going on with your physical system, your movement or mechanical system of muscles, bones, joints, nerves, connective tissues, and all of that, which may have been injured in an actual primary injury, but may have just gotten dysfunctional because of changes in these other systems. And so putting this all together, it's like you can have a variety of triggers that throw your system off and activate these systems towards a protective response that generates pain, amplifies pain, and causes the pain and other symptoms to progress. And so, you know, Where it really gets dysfunctional is when all of these changes lead to stuff like impairment of function and disability and breakdown in relationships, because then the person's life is really starting to fall apart. And maybe that's been happening to you or the person that you care about, the reason why you're watching this video. The other aspect is that these physiologic changes of our metabolic system, your mind-body system, and even your physical system, and lack of activity and changes in relationships and the way that feeds into all of this can lead to other chronic illnesses, which can feed back into all this dysfunction. So this is real and this is problematic. And the thing to know is that, like, the overall suffering of a person who's got pain is really related to all of these different things to one degree or another. And depending on your circumstance, various things may be involved in the way you're suffering on a day-to-day basis, the degree to which you experience despair or hopelessness about your life. And the average, like, musculoskeletal expert is not thinking about all these different things. And in my experience, there are many, many people who suffer more than they need to because someone's not thinking about the big picture. So I just want to take this and sum it up and say, look, if you just have pain in your knee, then go see someone who's really great at treating your knee, and that's a hands-on, in-person physical exam, get the scan, do the procedure, whatever it is. But if that's not working for you and you suspect you have a more complicated problem, then you might want to consult someone like me who's going to take a more integrative picture at the whole situation and understand it in the more of the complexity, which is the nature of the problem. So I just want to share a few cases just to illustrate what I'm talking about. Francine is 64 years old and she had neuropathy. She had burning in her feet, starting to affect her hands. She couldn't sleep, really overwhelmed by her pain. She'd seen a couple of neurologists who said, you know, your labs are all normal, you have a normal EMG, nerve conduction system, take these drugs. And guess what? The drugs gave her side effects and she couldn't tolerate them, so it wasn't a solution, but they didn't really have anything else to offer her. So she was in trouble. So she called me and we unpacked it, right? She had a vitamin B12 that was borderline low. It was normal, but it was borderline low. But in my opinion, someone with neuropathy with a borderline low B12, that's not normal for them. It should be in the middle range. And we actually checked an MMA, which looks at, it's a secondary test that looks at vitamin B12 function, and it was abnormal. And it suggested her body didn't have enough B12 function. So we treated her B12. She had a very low vitamin D. And a lot of docs still think vitamin D is, well, it's mainly about bone health and fractures and all that. But you know what? It's a pro-hormone. It affects pain transmission. It affects gut health. It affects immune regulation. All these different factors that are involved in those metabolic pressures on pain sensitivity. So we supplemented that. We supplemented magnesium, even though it actually wasn't very low. It was borderline low. But that can mean her body stores are very low because magnesium is in your cells, not in your blood. Blood's not a good measure of it. So it's fairly safe to supplement magnesium in someone who's got normal kidney function. So we did that. And she also had an increased inflammatory marker, which is a CRP. And her TSH wasn't quite normal. And we looked more deeply into those things. And she had a low-grade inflammatory thing. And she had low thyroid function. So we treated that as well, not with thyroid medicine, but things that got at the underlying inflammation, which is the most common driver of low thyroid. Her thyroid numbers got better, her CRP got better, she was 70% better. And that's just from what we did over telemedicine, because no one thought to look more deeply into this stuff. James had a really bad fall, broke both bones in his lower leg, had a pin in his tibia and screws holding it in, had horrible pain at the site of the fracture, but also pain going up his leg. They were just giving him oxycodone 3 to 4 times a day, and it was gorking him out, and it wasn't really holding him, wasn't letting him be functional in a meaningful way. He wasn't sleeping, and he really had this pain going up the inside of his leg, which no one even really tried to examine. They just said, oh, you got a fracture, so you got pain. No, what are you talking about? He developed gastrointestinal symptoms. He had a lot of emotional distress. He wasn't able to do his financial roles. He was really in a lot of distress on a lot of levels. And, you know, getting into the diagnosing a musculoskeletal thing by the phone, like I've seen 40,000 patients over 25 years, and I've probably seen that 50 or 100 times, that someone has a distal fracture or an ankle issue, and they develop soft tissue fascial function going up one of the tissue planes of the leg. And I heard it, and it was like classic. So I got him on the video showing me his leg and saying, "Hey, push here, push here, push." He's like, "Yeah, that's all tender." And that's a fascial restriction. That's a protective response in response to the pain in that foot. So I connected with him. I found him someone who does hands-on treatment, who addressed that tissue dysfunction. That helped him a lot. We also got his GI stuff under control. I taught him some mind-body stuff and got him connected with some tools to like rein in the anger, deal with the emotion, and just feel better about life. And 4 months later, he's like 40 to 60% better. He's able to do stuff. He's able to hang out with his kids. He's able to walk. Like, it was life-changing for him, and I didn't have to examine him. Last case, Jane, car accident a year before she saw me, had chronic pains in her hands, shoulders, knees. All the evaluations were negative, scans, all that kind of stuff. But she was in rough shape, and things felt like it was going out of control for her. And the questions nobody asked her were like, "How you sleeping?" "Well, I'm not sleeping well." "Well, what wakes you up?" "Well, it's not pain. I'm scared when I wake up." "What do you mean?" "I think I'm having nightmares about the accident. I wake up like shaking, and I'm thinking about it." "Well, tell me, have you been driving since the accident?" "No, I can't drive since then." "Have you gotten in a car?" "Yeah, well, my husband drives sometimes. I don't want to, but sometimes we have to. But we went by the site of the accident last week, and like, I thought I was going to die. I started having a panic attack. Like, I couldn't breathe. We had to stop the car." So she had post-traumatic stress, and her menstrual cycles were irregular. Her salivary cortisol was going high. Classic thing in post-traumatic stress syndrome. I'm not diagnosing that because I'm not a psychiatrist, but the physical signs of it were obvious. We actually tested her salivary cortisol, showed that it was elevated in times when it shouldn't be, got her taking some safe botanical substances that have been shown to modulate cortisol levels and anxiety: ashwagandha, phosphatidylserine, L-theanine. And so she was feeling a whole lot more calm in general. And the main thing that helped her was I connected her or helped her find somebody in her area who was a psychotherapist who did body-centered psychotherapy. And she had said initially, "Oh, I did psychotherapy, it didn't help me." Well, she did CBT. And CBT, cognitive behavioral therapy, helps a lot of people with trauma, but it doesn't necessarily get at the underlying autonomic dysregulation and sympathetic arousal that drives the trauma and drives the physical dysfunction that comes out of that. And so she worked with someone who worked more body-centered, not cognitive, body-centered, to actually tune into her pain and work with the emotional states that she was feeling in her body. And that was profound for her. And again, she had a major, major turnaround and was almost pain-free after a number of months. And so that was dramatic for her. It was gratifying to see. It's good when people get better. So these are some cases of how I work with people and some of the things that happen when we take an integrative view of pain problems. If this makes sense to you, if it's appealing to you, feel free to reach out to my office or to reach out to me by email if you're on my email list. And there is a longer version of this video available if you want to go into more details. And there's a lot more stuff on my YouTube page and blog, YouTube channel and my blog around pain and why pain happens, and a lot of detail about these relationships if you want to understand things in more detail. So regardless, I hope the video has been helpful. I hope you find a good solution towards your pain, and I look forward to being of service. Take care.